We shouldn't be treating a number on a scale. We shouldn't be treating a BMI, but we should kind of individualize our approach to treating obesity in terms of someone's health or even their risk for health.
Okay, let's talk in general terms. I feel like everywhere you look these days, there is some sort of discussion about semaglutide, Ozempic, Wegovy. Tell me in general, easy to understand terms, like you're talking to an elementary school student, what exactly are these drugs? What do they do?
Absolutely. So these were medications that were initially developed for treating type 2 diabetes, and they realized that there were beneficial side effects beyond controlling blood sugars, that including helping people to achieve a healthier weight and also treat some of the complications of excess weight beyond diabetes. These are natural proteins that exist in our body called incretins. And what happens is when we eat, these get released into the bloodstream and they signal to the brain that there is food in the system, signals to the gut that there's food there, so it slows down to aid digestion, and also signals to the pancreas where the insulin is produced that there may be food there. So when the blood sugars goes high, that it can then help to control blood sugars. So these together help people to not just manage diabetes, but in people who don't have diabetes, can help them to support kind of a nutrition plan that supports a healthier weight.
I hear a description sometimes of people saying they feel full. Is that what the goal is, that it helps people feel fuller and then they eat less?
What this does is helps people to interact with food in a different way. What I'll say is that there are a variety of different factors that influence how we eat and what we eat that are well beyond kind of what we've planned to do. The challenge is as well is that when people are living with obesity and when they've lost weight, there can be changes within our system that can support weight regain once we've lost them. And I think that's one of the challenges. Unfortunately, we don't look at obesity as a chronic disease. And what we need to do is kind of reframe how we do this. What these medications can do is to help us to be satisfied with less food for longer. And what that does is it kind of shifts away the healthy eating pattern away from this kind of unhelpful restrictive pattern that I think many people have approached obesity with for many years. I just need to cut out food. I need to not eat foods that I enjoy. What this can do is can help us to be satisfied with less. So instead of working out what we have to cut out, we can instead focus in on how can we create a balanced, healthy diet that gives my body what it needs.
You said, unfortunately, we don't look at obesity as a chronic disease. Is that the way we should be thinking of obesity? Because I know it is truly an epidemic in America.
Absolutely. We need to reframe obesity the way we would blood pressure or cholesterol diseases. And what I mean by that is there's so much talk in the media about what happens when we stop medications that treat obesity. People do regain weight, but what happens when we stop medications that treat hypertension? People's blood pressure goes back up. They don't go to the doctor's office, start blood pressure medicines because their blood pressure is high, control their blood pressure, and then stop the medications. We would expect their blood pressures to go up. The same thing with obesity. When we have people who are living with obesity, who have their disease treated, and they get their weight to a healthier range, we need to continue treatments that are working rather than stop something that's working and expect people to maintain a healthier weight.
Who do you believe that this is right for? Talk about the kind of patient that is a perfect candidate for these weight loss drugs, and compare that maybe to somebody who maybe would just be doing this for vanity purposes.
I think that's a very tricky question to answer. When we look at the indications for treating obesity, they're focused around BMI, which is a ratio of our height to our weight. And they're indicated for people who have a BMI of 30 or greater, or those who have a BMI of 27 to 30 with a complication related to their weight. And that could include something like high blood pressure or diabetes or obstructive sleep apnea. When we talk about who is right for these medications, it's right for treating obesity and it's covered for people when they meet these indications. However, there are a section of the population in whom they may develop complications at a lower weight. And so it may be appropriate to treat them at a lower weight. And why I say that is it's important for us to individualize obesity care. We shouldn't be treating a number on a scale. We shouldn't be treating a BMI, but we should kind of individualize our approach to treating obesity in terms of someone's health or even their risk for health issues, such as the future development of diabetes or heart disease or the complications related to weight.
What types of outcomes are you seeing? Are you seeing success all across the board when you prescribe these drugs to obese patients? Or is it not necessarily that everyone sees success?
When we're treating obesity, there's a lot of what we call heterogeneity or variability in the kinds of responses that we see, be that from a dietary intervention, exercise intervention, anti-obesity medication therapies, which is what we're talking about today, or bariatric surgery. So we see a lot of variability in terms of what there is in terms of weight reduction. And what we need to do is follow patients and work out, is this medication or is this intervention working for you? Are there things that we need to do in order to optimize in terms of supporting healthy, balanced nutrition, physical activity, and other challenges? And are there things that we can do to change the therapies if they're not working? I think it's also important to highlight that some of these medications also work for improving type 2 diabetes. There are studies that show that they improve kidney health for people with diabetes. And there's a recent large study that shows that they decrease the risk of heart attack and stroke in people who are high risk. And so what we need to do is focus in maybe not just on the weight, because people would likely experience these health benefits even if they don't achieve very large amounts of weight reduction. So I think it's short-sighted to just look at outcomes of treating obesity by just looking at a number on a scale.
That's important, I think. It's good context to think about the greater good versus just, what's happening on the scale. You talked about you talked a little bit about the effectiveness of this, but I do want to ask you about sort of counseling patients when it comes to insurance, because I know in some cases insurance will cover it. How do you talk to a patient who's concerned? They're not cheap. So how do you talk to a patient who's concerned about affordability of these drugs?
There are a lot of challenges when these medications aren't covered by insurance because they're quite expensive. What we do is we help patients to work out, are they covered or not, by checking with their insurance so that we know what all the options are, what the costs are, and then we talk about which agents may be most affordable and practical for that patient, given all of the kind of challenges around kind of cost and coverage. Many people aren't aware that it's not the insurance companies that determine coverage, but their employers. And so talking with someone at the company where they work, perhaps in their human resources department, about, are these medications approved benefits for employees? Are there things that we can do to improve access so that we can get evidence-based treatment for obesity care? These can be great places to start.
How do you feel about compounding pharmacies? I know there's some concern that, if you're not taking the brand name Ozempic or Wegovy, you don't know exactly what's in the shot you may be taking. So what are your thoughts? How do you counsel patients who ask you that question? Hey, I can't afford this, it's not covered. Can I go to a compounding pharmacy?
When I hear that patients are interested in compounding pharmacies, it's usually because they're unable to get the medication because of coverage and cost issues. It's challenging because the FDA and many of our professional societies have been very clear that compounded medications should not be prescribed because we really aren't sure where they're coming from. These are patented medications that are intellectual property of large pharmaceutical companies, and they are not providing the medication to compounding pharmacies to be compounded and sold to the public at lower prices. So we're really not kind of sure what it is that patients are accessing when they go to compounding pharmacies. So this is not something that we recommend in our practice.
Just a few more questions for you here. You talked about the fact of the matter that we shouldn't look at this as something you just take to lose weight and then get off of. So have you been prescribing it long enough to see someone who does stay on this sort of for the long term? I mean, that this is something that somebody might take for years and years because it is helping them keep the weight off. I guess what I'm asking is the long-term effects, and is that going to be okay if someone stays on this for the foreseeable future?
I think these are wonderful questions. I've been treating obesity at UT Southwestern since 2012, and I've been using these medications since the start of my career. And from what I've seen, these medications are largely very safe and effective and are used very well for treating not just obesity, but controlling complications related to obesity. And as studies show, preventing risk for things like heart attack, stroke, and kidney damage in our patients with type 2 diabetes. And so what I think we need to do is contextualize how we approach treating obesity as a disease, how we can help people to achieve not just a healthier weight, but to avoid the complications related to living with obesity. But then also maybe we can take even a few steps back and think about, what would it be like if we treated people before they developed obesity to help them achieve a healthier weight? We could probably prevent a lot of complications too before they even start.
Interesting. So 2012, Are you surprised that here we are in 2024? I guess this trend sort of started in 2023, maybe. Are you surprised to see sort of the general public finally have this aha moment and awaken to this, and for the popularity of these drugs to now be skyrocketing?
I'm very excited that people are looking at obesity as a disease and what treatments are available there to them. I think it's exciting that we have therapeutic options that are both safe and effective. I think we can all think back to a time when anti-obesity medications were on the market, were withdrawn because of complications related to heart issues or other things that made people think that medications that were used for weight management or treating obesity were either unsafe or ineffective. But we're in a completely different era where people can access therapies that are pretty much equivalent to bariatric surgery. And I think that's really exciting, where patients have more options for treating obesity and preventing complications.
Are you now prescribing more of these drugs than counseling people to have those weight loss surgeries?
I think what we need to do is look at what is the most evidence-based therapy for the patient in the room. And it's hard to generalize. I think when we look at people who are living with severe obesity, interventions like bariatric surgery may be the most appropriate therapy for the patient there in terms of weight reduction. And I think there's also kind of to look at, well, what is the patient able to get in terms of insurance coverage and access? Interestingly, there may be better coverage for bariatric surgery than anti-obesity medications for some, especially older adults. And so looking at what is the best therapy there, when we look at this as a complex disease model as well, we might think, well, maybe we need to help somebody to achieve greater weight reduction with an intervention that's safe and effective, like bariatric surgery, and look at how can we help them to either maximize their weight reduction or to maintain the weight that they lose long term by using therapies like anti-obesity medications.
Do you consider this sort of a miracle drug that people talk about, a miracle drug to lose weight?
So with regards to that, what I will say is a lot of patients every day will tell me that treatments like this have been game-changing for them. Many people who've lived with obesity for many years and who've tried a series of restrictive diet and exercise and other programs, and even those who've tried older anti-obesity medications, when they start medications like this, there's a dramatic change in terms of how they interact with food, how they think about their kind of nutrition, and how they can then approach things in a way where they feel less restricted and less constrained, and they can focus more on balance and more about health.
Would you say that interest in your program has increased through the years? I would imagine that as more people understand that there are options for treating obesity, and it's not just about, like you said, the food you're eating or the exercise, but there's other treatments available. Have you seen people flocking to your program in a way that's different, would you say, now that the people realize these drugs are out there?
I think there's been so much talk in the media and social media around these new treatments for helping people to lose weight. And so there's always been more of a demand for our program than we were able to meet with regards to appointments. But I'm excited that people are talking about treating obesity as a disease, and that we can collaborate with our primary care colleagues and others in the community to help to treat obesity with these evidence-based therapies.
What are the things that someone needs to consider? And what does the discussion need to look like if they're going into their primary care physician or to any physician? Or now we know that, you know, some spas and things like that are offering this now too. What are the conversations that a patient needs to have? What are the things they need to consider before they take these drugs?
This is a wonderful question, because I think many people may start these medications without having adequate health assessments and education about where they're at on their journey with their health, independent of their weight. Unfortunately, many of us living in this country, the quality of our diet is not great. And if we then start a medication that just makes us feel less hungry, we may be eating less of a lower quality diet, which then sets us up for issues, including nutritional deficiencies and malnutrition. What I mean by that is there's a lot of talk about people, for example, losing lean mass with medications like this. It's important to make sure that we're eating an adequate amount of protein as we start medications like this, and the required amount may vary based on what our health status is at baseline, and also make sure that we are as active as possible, focusing in on resistance training to help to keep our muscles strong. I think it's important along the path of this to follow up with a healthcare provider regularly to see if any medications, such as blood pressure medications or diabetes medications, need to be adjusted to make sure you're not on too much of a good thing and to make sure that your weight loss journey is healthy.
Is there enough of a difference between like Ozempic and Wegovy and Mounjaro and some of the different brand names out there that that is something that people need to consider as well? Like, do they need to do their research on these different drugs in order to find out which does which, or is that something that they're all similar enough to where if one doctor prefers one that you should trust that?
These medications that we're talking about are largely from the same class of medications, the incretin class of medications, so they have quite similar mechanisms of action. There are no head-to-head studies kind of pitting one against the other that are currently available. Based on the clinical trial data and kind of looking at the results, if we looked at magnitude of weight loss, for example, tirzepatide, which is sold for weight loss as Zepbound, or approved for type 2 diabetes as Mounjaro, does appear to have greater weight reduction, but those clinical trials lasted longer than those for semaglutide, which is Wegovy, or Ozempic, which is marketed for type 2 diabetes. And so it's important to look at the context. It's also important to look at what other data are there. For example, we have cardiovascular data for cardiovascular risk reduction for semaglutide for people who have a history of cardiovascular disease in terms of decreasing the risk of heart attack and stroke. So we may want to look at what's the underlying health conditions that are there that the patient has, but also what is the destination that we need with regards to weight reduction.